also like to welcome you on behalf of MIT Symposium to attend this conference. And as you know, healthcare touches everyone. It's a caring of everything. So many transformations are happening, so many changes are occurring in the healthcare. And CIOs and technology leaders in the healthcare are faced with humongous problems, or challenges, I would say. And we have a stellar crowd of panelists here, 4 panelists, and they will walk through us how they are navigating through this healthcare transformation. And for the moderator, I would like to introduce Dr. Sridhar Padravasu. He's quite well. He's MD himself, as well as he runs his own business in the healthcare for a long time. And I will just take a lead and drive this panel.
Thank you, Naeem. Welcome to all of you. Welcome to the panelists. Let's begin this afternoon's session with a quick introduction by each of the panelists. Joe, we'll start with you, and we'll work our way down this way, and then we'll get started.
Great, thanks. Hi, my name is Joe Alea. I've been in the software industry for 30 years. I started in healthcare back when I developed systems for pharmaceutical companies to do provider profiling. And then I segued into building a product called CCMS that was for health payment review that ultimately was acquired by McKesson. Fast forward to the last 7 years prior to my current company, I worked for a company called Phase Forward that we developed systems for life sciences to around drug delivery from protocol authoring through submission. And I recently joined, about 5 months ago, a company called CureSpan, that health group that we specialize around patient transition management of connecting discharging patients from provider to provider and looking at the entire continuity of care. Thanks.
Great. Kathy?
Hi, I'm Kathy Bruno, and I'm the Vice President and Chief Information Officer for Eastern Maine Healthcare Systems. I am also the Executive Leader for the Bangor Beacon Community. And I've been in healthcare for over 20 years and just love working with the whole healthcare mission.
Hi, I'm Chuck Podesta. I'm the CIO of Fletcher Allen Healthcare in beautiful Burlington, Vermont. This is the time of year to get up there if you want to go visit us. Fletcher Allen's an academic medical center in Burlington, Vermont. We also had a community hospital join us, Central Vermont Medical Center, last October, and we have a letter of intent from another hospital in northern New York. So we're rapidly growing from a standalone academic medical center to a true integrated delivery system, so we're excited about that.
Hi, I'm Sue Shade. I'm the Vice President and CIO at Brigham and Women's Hospital here in the Boston area. And no, it's not always like this weather-wise. You missed a gorgeous weekend. Brigham and Women's is a close to 800-bed academic medical center that was a founding member of Partners Healthcare, along with Mass General back in 1994. We've grown. We've got a number of community hospitals, specialty hospitals, as well as our non-acute care division, our physician network. I have responsibility for IT at Brigham as well as at Faulkner Community Hospital of about 130 beds, and Dana-Farber Cancer Institute, which is also has a joint venture with us. And I've been in healthcare IT management for over 25 years now. In this position for the last 12 plus, was in a system in the Chicago market for 12 plus, and in between I was at a small vendor and consulting firm, so kind of been on all sides of the table.
Awesome. Well, if this group doesn't have all the answers, we're in big trouble. So we're going to focus today's theme, and everybody's pretty familiar with the issues around health information technology. There's a lot of controversy. We're going to try to stay away from the controversy as best as we can. But if you lead yourself down that path, then I'm going to keep going at it. But we're going to take an example and I'm going to keep coming back to this example because this team represents various aspects of the healthcare system today. And I'm trying to get an understanding as a layperson. If I'm a 50-year-old male that works for Raytheon here in Boston, and I have a history of cardiovascular disease, high blood pressure. I'm a patient of a physician, let's say at Partners, and I receive my primary care through Partners. I want you to remember all these facts because they're going to be relevant when I weave them through. We're going to talk through that scenario of all the people that I interact with within the community to see how technology is really going to help me as the individual. I'm going to keep coming back to this. So, topic number one is, what is your biggest nightmare so far in terms of implementation of technology that you've experienced? And it's only got to be one. So, Joe, we're going to start with you. What has been your biggest nightmare so far in terms of implementation of HIT?
Well, being that I'm more of a vendor, you know, I'm not quite, you know, I think the people here to my right can actually speak more about their nightmare. But from a vendor standpoint, I think the biggest challenge that we have is being able to deliver solutions that meet the mark and add value. So around the technology front is really being able to partner with, you know, as you know, the whole healthcare industry is very fragmented. There's significant amount of proliferation of technologies, data, and so forth. And being able to really bring all those solutions to people is one of our biggest challenges because of the lack of data semantics, the lack of context around the data, and being able to really hone in on the real value of that data to make key business decisions.
Okay, and that's still a little bit generic. So from a buyer's perspective, if you're a hospital, Sue?
Actually, I'm going to pick up on the word fragmentation.
Yeah.
And I'm going to tell you that we do have a level of fragmentation within our organization right now because we don't have common solutions for our clinical systems at each of our entities on the inpatient side, though we do on the outpatient side. We are moving in the direction over the next couple of years where we will have one common solution at the enterprise level. So we do a lot of integration. Results get fed into our clinical data repository, viewable at all of the institutions through what we call a results viewer or through the ambulatory EMR. So there's certainly a level of integration, but there is still a degree of fragmentation, and we also, so you worry about that from a patient care perspective, if not all information is easily accessible enough to the caregiver.
And that's your biggest nightmare?
It is.
Okay.
And can I just, I will just add, I know you're trying to move it on. It's, you know, from a patient's perspective as well as from a clinician's perspective in the workflow and how hard it can be for their workflow when you have some level of fragmentation.
But Kathy will disagree because Kathy's had a lot of success. And Kathy will say that her biggest nightmare is not enough money.
Actually, we have had some issues in systems implementation. And the times that we have issues in implementation are when we don't get the right participation from the folks who are going to use the system because healthcare is complex. And one example is when in our tertiary hospital at Eastern Maine Medical Center, we went live with computerized provider order entry. And when we were developing the order sets and workflow for the cardiology group, they were too busy. They didn't have time to work with us, so we worked with their nurses and their assistants, but we didn't actually work with the cardiologists. And then we went live, and they said, well, this doesn't work. And so we had to spend 6 months redesigning it, working with the cardiologists so that it did fit into their workflow, because it turned out that there were a lot of protocols that they were using, that they were used to using, that we hadn't programmed in because it wasn't communicated to us.
Right, and an important thing to mention, once you talk about being as Naeem says, and I think it's fair, being the beacon of the beacon. So you only get 10 seconds, but you get to do your little ad here.
my ad for the Bangor Beacon community?
Yeah, sure.
The Bangor Beacon community is one of 17 beacon communities in the United States, 3-year, $12.75 million grant to improve the health of the people of the Bangor community. And we're doing that through care management facilitated by health information technology. And in a nutshell, I'll tell you Patty's story. Patty is a 74-year-old person with chronic obstructive pulmonary disease. And before the Bangor Beacon community, she was going by ambulance to the hospital 9 times a month to control her symptoms. And working with a care manager, appropriate medication management, nutrition, watching her salt, having someone to call when she started feeling that way to manage her symptoms, she, in the last year, hasn't been to the hospital. So this is a huge breakthrough for these people with these chronic diseases, and we're doing that 1,000 times in Bangor.
Chuck, what's your biggest nightmare?
Let's see. I have quite a few of them.
Oh, God.
When I
Only
was
one, Chuck.
when I was younger, I took a COBOL programming job, and I didn't know COBOL. That was a nightmare. But recently,
Okay, we're going to focus on the
I
healthcare
know.
IT piece here.
I know I need therapy. So we went live with Epic a couple of years ago, and about 60 days after we went live, a squirrel hit a transformer, blew out our UPS. Our failover did not fail over, and we were down for 8 hours. So that really tested. Luckily, it happened actually 2 months after we went live, so people remembered the old paper system. If that had happened 10 months or a year after we went live, it would have been even worse. But that was a long day, and many long days after that.
So I'm going to come back to my previous example, and then each of the panelists is going to have to tell me, up until now, with what you've done with health IT, how you've helped me, the consumer. And we'll get back to this topic again a little bit later. But if I'm this 50-year-old employee of Raytheon, what has technology done for me, Sue? How have you helped me, the consumer in Boston? What have you done so far?
Sure, what have we done so far? So I mentioned that we have one common ambulatory EMR that is deployed across all of our primary care and specialists throughout the partner system, 100%. We're working on meaningful use now in terms of achieving all the specific criteria, but it's been in place, and it's been in place for many years. So there's that consistency when you're visiting your physicians, regardless where you are in the system. We also have a patient portal called Patient Gateway, which allows you as a patient to log on from anywhere that you are to schedule an appointment, get a secure email message with your physician or the office practice, get prescription renewals, get health information, get test results, etc.
Is that easy for me to use?
It is. It is. It
Okay.
is. Yeah, it's pretty easy for you to use. Can it be improved? Always. I'm one of those dinosaurs that has an AOL account, and AOL just changed their whole look and feel, and it's cleaner, nicer. I mean, everybody's improving.
Right.
You know, so we need to keep evolving our product as well. Both those products I mentioned are internally developed, not vendor products. And we've also done a lot of work in the telemedicine, connected health space as well. And pretty certain we've probably done some stuff for a patient like yourself.
Got it. Joe?
So the thing that we do is we help patients, we do the coordination of care from provider to provider. So to answer your question, every day what we do is help case managers place patients in the right setting.
So suppose I had a heart attack,
Okay?
and I've now left the hospital. Take me through there, because the biggest problem is, what's the problem now in the new scheme from a hospital's perspective if I bounce back into the system?
Readmission.
Yeah.
Yeah, we want to prevent readmissions.
Right. So how do you help
So
that?
what we do, well, the thing that our software does is to help hospitals reduce their readmission rate and their length of stay. And the way we do that is to provide the case managers with the ability to hone in on the right post-acute settings for that particular patient. Now, we have statistics based on what each of those post-acutes have done in the past. That's accessible to the hospital. But the most important part is that we still give the patient a choice, because that's required by law. So it's all about providing the right level of information to the case manager, to the patient, and then coordinating all those things, whether it's home health, transport to the post-acute. And it's not just about the SNFs or the skilled nursing homes, but it's also about dealing with the home health, and we're doing partners with companies that specialize in that as well.
So that seems like a heck of a lot of information between the hospital and the care coordinator. Chuck, do you buy that? That sounds like utopia to me. It just sounds too good to be true.
Yeah, Joe's a vendor. One aside, though, that we did was last year we did a study of all of our heart failure patients. We called every single one of them 5 days after they left the hospital and went through their discharge instructions again just to see how they were doing. And we found that in 50% of the cases they were doing something wrong.
Who is they?
The heart failure patients. They were doing mostly around medications.
So how is
nutrition.
technology improving that, Kathy?
One of the things that technology does is it can notify. So it can notify the primary care physician that my friend was just discharged from the hospital after having a heart attack. And so therefore there can be a follow-up with that. My dream would be to have someone actually go to the home and look at the medications, because I think one of the possible errors, if someone gets a new prescription when they're discharged, but they already had some medication, sometimes it's confusing whether they're supposed to continue to take the old one or whether they're supposed to take the new one. And so someone to talk to about that, and that's the person that's our care manager. I think what would be ideal in the long term, if we ever have a single payment, would be to have people who could actually do that medication reconciliation and make sure that you know which medications you're supposed to take and which ones you throw away because you're not supposed to take them anymore.
So Kathy has a dream, and she's going to be out of $12 million pretty soon. So Sue, what happens next when the money runs out to go the last few miles? Because these are great things that need to happen. But who's going to pay for it?
Well, the organizations have to pay for them if there's not additional funding for these kinds of programs. And I think that many of these programs are considered pilot, proof of concept programs to see what the results are. And I think once those programs are successful and organizations see those results, they may be much more willing to, get their own skin in the game and make the investments that are necessary. When it comes to it, any of our organizations are really about delivering high quality, safe care to patients, and we're going to do, what it takes to achieve that.
How much does government need to be involved, Chuck?
I think they'll be incredibly involved, especially when we get to, for example, global payments, with readmission rates. You can see that if you're on the top end of that and you have very high readmission rates and you get dinged, you're going to pull a team together in a very quick fashion, and if it's technology that's going to help solve that problem, you're going to get the money for the technology to solve that problem. Unfortunately, it's one of these things where, you don't put the red light or the traffic light up until there's an accident at the intersection, and I think you're going to see a lot of that in a lot of healthcare organizations going forward. I think the ones sitting here, hopefully, were ahead of the curve, but I don't think you can say that across the entire United States.
Why is that, Joe? Why are only these folks ahead of the curve?
Us?
Well, they're singled you out. No, I'm just kidding. No. Yeah, why are all of you ahead of the curve? Why do you think you're ahead of the curve and the rest of the market isn't? What's the?
I'm not quite sure if I tend to agree that we're ahead of the curve. I think we'd like to think we're ahead of the curve. I think there's, if you look, I just recently went to HIMSS, and there was about 400 vendors at HIMSS, and everybody's telling the same story, and everybody has the same solution, and, everybody pitches HIE and this and that. But at the end of the day, there's no unification around it. I think the systems that are out there are still not meeting the mark. And a lot of it, I believe, is centered because the technology that's out there is built, it's flawed because it's built on business models of the past. And I think the new business model going forward has to be centered around the patient. And being around the patient and having patient data and being able to aggregate that patient data is the key. So, you know, I equate it to having a car going 100 miles an hour and trying to change a tire while it's moving. And there's always, you know, you mentioned that there's cost. The dollars are going to go away from your funding. Well, the similar happens from a technology company. We're always balancing what the needs that are required today versus what the utopia should be from a total technology standpoint. So, you know, it requires patience and it requires some great vision that I believe that companies are moving towards. But at the end of the day, until you have the right data models with right informatics and analytics to really look at that information, I think we're a ways.
Can I jump in on that? So, I mean, to say that, you know, we're organizations that are ahead of the curve, yes. Why is some of that? We made investments probably earlier on compared to other organizations, had the ability to do that, had the leadership support to move ahead on some of the advanced clinical systems that were needed. But I will tell you, in my organization, we have not yet attested for meaningful use. You might think, well, gee, you've heard about Partners, you've heard about Brigham. We've had CPOE at Brigham since the early 90s. Okay, we've had this ambulatory EMR since, you know, I can't remember when, in the last 10 years, and fully rolled out to all of our PCPs and specialists. But with the meaningful use criteria being as specific as they are and progressing over time and kind of raising the bar, it's absolutely the right thing from a care perspective. So, you know, we still ourselves have work to do to meet some of those criteria before we're going to be ready to attest. So whereas we've been leaders in some areas, we have a ways to go too. So it's like, you know, we're kind of all in it together in terms of moving the dime forward or moving the ball forward in terms of the level of the systems, how they're used by our clinicians to really be effective in, you know, patient safety and quality of care.
So,
Could I follow up on that too, please? I'd like to follow up on your question about the government involvement. And I think that the government being involved in having the incentives for the meaningful use is bringing everybody up to a level that we never would have had. If we, at Eastern Maine Healthcare Systems, we are leaders, but we would not be moving as quickly as we are now. We have 7 hospitals to roll our systems out to, and we would have done them one at a time and been very conscientious about it. We did one a month.
So how does that become,
but
how does that, I think that's fantastic, but how does that become scalable? So how does that happen to every hospital? Where does the money come from for that?
Because the federal government's paying. And
well, outside of the grants, though.
No, I'm talking about the meaningful use money. I mean, just we made $20 million more than we spent to bring ourselves to stage 1 meaningful use. We've already collected 7 of it. So, and we're on the track to get the rest of it. A lot of it's for, actually we're getting more for our doctors than we are for our hospitals. So the federal government through the ARRA is paying incentives to hospital and doctors to have what's called meaningful use of electronic health records. And the other thing that the feds are doing is they're helping with standards. We're having standard code sets for things like allergies, standard code sets for things like problem list, those kinds of standards which will make interoperability make sense. If I get a continuity of care document into my one doctor's system, it's the same code sets that's being used in the other doctor's systems. And that is a huge, before the feds were telling us to do that, nobody was making standards. They were just sort of getting around to it. There were some standards the academics were making, code sets like SNOMED and things like that, but there wasn't a pressure to actually adopt them. And now we have financial incentives to do that.
So what is the reason behind this sentiment in the country what is the resistance that in any survey you see today, that the overall sentiment around how we've changed the system is so negative? Chuck, why is that?
I think some of it's understanding. You know, if you look at the law and the parts of the law, PPACA, ARRA, I mean, even at our levels, it's very difficult to understand all the various components of healthcare reform and what's actually going to change. I mean, think about it. You go from fee-for-service to quality and cost as being the drivers, and trying to wrap your head around that, just even in the healthcare business, how can you expect the community to understand how that's going to be good for them in the future?
So on that point, Sue, if I'm coming back to my example, if I'm trying to shop around and I need a procedure done, for me as a consumer, cost is a big deal. What is it that I'm going to do, need, have available to me in terms of understanding cost? Forget about quality right now. What can I find out about cost? What have we done to help that? What have you, the hospital, helped for the consumer to understand?
I don't think you can find out that much, quite honestly.
Cannot?
I mean, no.
Why?
I think, I'm not sure. But, you know, pricing, in some respects, the fact that someone else is paying for it in most cases in terms of the insurance companies, you just don't see that much information about pricing. Cost information, you know, at an aggregate level is not published that much, at least to the consumer, though I think that's changing. And, you know, consumers, you're absolutely right, are shopping around more. I'm not sure how else to comment on that in terms of pricing information that's really made available to patients.
Joe, is technology being used? You talk about you talked about the business model of it being patient-centric. So if I'm, you know, anybody in this audience right now, you know, quality is important again, but right now the bigger crisis is just getting people the ability to buy health care. What are you doing to help that?
What we're trying to do is, again, we're shifting to more of a patient-centric model. We want to be able to follow the patient from provider to provider to provider and really understand what the services that are being rendered there, and being able to take that analytic and be able to provide it to risk-bearing institutions like CIOs and payers. Now, keeping in mind that a lot of this stuff is all about, there's a significant lag time in understanding cost, right? You know, it's very easy to, 6 months down the road, really get the analysis of what the cost is. But I think the true measurement around cost for curtailing it is understanding what's happening in real time. And that is something that we're really anxious and looking at.
What do you mean by real time? What's an example?
Well, so what happens when the example I would give is, being able to provide information for inline business decision making. So if a patient hits the floor at a hospital, for example, and you have enough information about the context of that patient, what they're there for based on some demographics of age, for example, in the procedure, DRG procedures, you can certainly assign a weight to it, or a risk weight, that perhaps maybe you do some interventions or some case management or some education. A lot of readmissions, can be dealt with not just from a clinical standpoint, but from an educational standpoint and from a right placement standpoint. So anything along those lines and measuring those kind of costs would go a long ways to be able, not so much to the consumer, but certainly to the hospital. From a consumer standpoint, I'm not quite sure if I have an answer around that.
Sue, if my cardiologist has told me I need a stent and I go to get a second opinion, what should be available to the second cardiologist?
We're not talking pricing now. We're talking clinical information.
Yeah, I'm talking about, let's assume that I'm the second cardiologist and I need to know in the community here what it is that I should have available on that patient. What do you think in the ideal, even before they come to
Sure.
the hospital?
Fundamentally, you should see what procedures or tests have been done and what's the results of them, so that they do
Right.
not have to be redone,
Yeah.
reordered, and redone.
And Kathy, do you think we can do that now?
I think we do it in various ways now. I think that
What do you mean?
if that, right now, if that second opinion is within our healthcare system, then that information is available because we have a central electronic health record. If it's somebody that's in another city and is some of that information, if it's in Maine, is in our health information exchange.
Right.
And then if it's beyond that, then they'd probably have to fax the paper record.
Right. And do you see that changing in 5 years?
I think it will change. I think that there are evolving standards, and I think that the system vendors are being forced to accept those records where they didn't have to before. And I think most of the vendors could send a record, but the accepting part, and not only accepting it, but putting the data in the right place, like if it's the medications or the problems or the particular results, then I think, yes, I think that the standards are coming down, they're getting clearer, and there are incentives to follow them.
That's another area of government involvement, because with stage 2 meaningful use, it's all about what Kathy just said.
So who else then? So I work for Raytheon. My employer is paying the benefits, Chuck, for me to get the care. Mm-hmm. What is your expectation that other stakeholders, whether, and my insurance carrier, let's say, is United Healthcare, what is your expectation of outside of the care delivery system? What kind of information needs to be accessible and exchangeable for me as the consumer in order to optimize my care? Does my employer need to know? Does my payer need to know? In a patient-centric model that Joe is talking about, what are the pieces that need to come together?
Well, I think from a payer provider, there needs to be a partnership. Right now, there's not. I mean, we're bitter enemies most of the time. So in a fee-for-service world, but I think you're going to see that change, because when you look at medical management, who's doing that medical management? Well, we do it on the provider side. The payer does it as well, and who knows who does it better. We all think we do it the best. So if you can start to look at those types of processes and say, okay, let's do a deal where I'll do the care, I'll take care of the patient, you do the medical management, and cut costs out of the system that way. From that standpoint, then I think the employers will start to see that the payer and providers are coming together in some sort of partnership in a way that's good for their employees.
But yet the payers will say, and I've heard this in the last few months when we talked about pricing transparency, there's a big push in consolidation within markets now, right? So the bigger hospital systems have no incentive to publish prices, right? It's only the smaller players. So does technology really become the enabler, Sue, in terms of information flow, or are there still vested interests? You don't have to speak on behalf of anybody, but I see there being a real contradiction in the market between this philosophy that technology needs to be the driver in terms of information exchange, but there's still vested economic interests where data really doesn't flow freely.
So we want to hold the data and not share it, is that what you're saying?
That's what I'm hearing. I mean, so the rates that are negotiated between the payers and the providers are not always published nor accessible.
Mm-hmm. Yeah, I think, how things are changing, though, is that we're having more and more contracts where we're at risk in terms of pay for performance. So as Chuck talked about, the closer working together of the payers and providers is just, it's a fact now. It's what we're doing. As far as the information, there's privacy in terms of, who can see the patient's information, but to care for the patient effectively, we cannot hold that data as just ours if in fact that patient is being seen in many care settings. And we need to share it with other caregivers in order to take care of that patient, ultimately reduce the cost of the care of that patient.
Kathy, how are analytics being used in your experience now? There's this big buzz in every sector around big data. Healthcare is inundated with big data, but what have we done successfully in your mind around analytics to help improve cost and quality of healthcare?
At Eastern Maine Healthcare Systems, we do several things. We use our data warehouse to monitor the quality of the patient record to make sure that we're documenting appropriately. So that's a very operational use for it. We use it to develop guidelines. For example, we studied our transfusion processes and looked at blood use, and we have greatly improved our blood use by building in appropriate order sets and guidelines, but we had to use the data to analyze it in order to know what we needed to change to improve our blood utilization. So we use it for analytics there. I would say that it's not one of our strong points at Eastern Maine. It's something that we know, well, it's our strong point in terms of day-to-day patient care. We're really good at that. But to move forward for population health kinds of analytics, where you want to bring in the information from the payers, you want to be able to analyze data over large populations, is something that we're not familiar with. And so we're working with partners. For example, right now we're working with Geisinger to learn what they're doing, because they're several years ahead of us in that kind of analytics because they have their own health plan. So we're learning from our colleagues who are already doing those kinds of things, but because we're a pioneer accountable care organization, we get tapes from Medicare with the claims data, and we don't have the skill of analyzing that. So we're working with partners to help us do, not Partners Healthcare, but Geisinger.
Right. So Chuck, what do you do? Because is this something, you have Cerner, you've got Epic, you've got Allscripts. How many different systems can you possibly have? Is there truly, and I say that rhetorically, don't answer it.
I know.
But this whole notion of Switzerland, that there is this neutral ground that can help synthesize all of this and still enable Kathy or Sue or Joe to do the analytics. Is that possible, and have you seen examples of that?
I think it's possible around the edges, but not from the standpoint of an all-in-one solution that you can, pull off the shelf and plug every single EHR into it and start spitting out analytics. I don't think that exists today. You've got issues around natural language processing, around textual types of data. How do you store that? How do you normalize the data across those various systems and also across different hospitals? Depending on your lab values, you could have different normal ranges in those lab values. So how do you bring that data together? I think the standards are going to help quite a bit, but I think we're a long way off. I think we're just getting the tools in place now and getting the understanding. Even internally with my IT team, when we started building our business intelligence group and started talking about a universal developer and a star schema, and these are smart IT people, just, deer in the headlights. So we're learning a whole new language just within healthcare IT around business intelligence. So I just think we're in the very early stages of maturity there.
Joe, are we building more islands that are never going to connect?
I think we are definitely building more islands. Whether they're ultimately going to connect, I hope they're going to connect. I think they will connect. I do agree with what's happening with what Chuck said about the data. In big data, if you look at life sciences, there's a lot of genomics going on with personalized health happening there around big data. But I think the way I look at big data is a little bit different. Big data could be just a small number that you can't understand, and there's a lot of noise to it. So for me, I think what you have to do is find small battles where you can find specific patterns of data that either help with a readmission or a length of stay or better care. And I think if you think big, but you execute in a very tactical manner, I think big data has value as long as you don't try to boil the ocean with it and you stay true to it.
I'm going to switch gears here a little bit, but I'm going to tie some themes together. Sue, what can we learn from Facebook that can be applied to healthcare?
That's a great question. Wow. I think a couple things. Number one, I think our next generation of workers, and in many cases the residents in particular, have grown up and lived with this and want to push the edges and use it. One of the first problems that you run into is privacy of information. So then you put in your social media kind of clamp down policies. You have organizations that say you shouldn't use Facebook at all at work, and you shouldn't even be able to let people have access to them. And then on the other hand, you've got marketing and public affairs departments that are trying to promote it. And we've had that whole debate. I think we settled in a good middle ground. One of the proposals that came out of our Brigham Leadership Program, which is mainly for up-and-coming physician leaders, but also heads of other clinical areas, was a Facebook-like application that would solve the simple problem of, especially in an academic medical center, patients not knowing everybody who's taking care of them. So you've got your attending physician, you've got your resident, you've got possibly a student, you've got your nurses, you've got your shift changes, you've got your consults, you've got, all sorts of people in and out of the room. It's like, who's my care team?
Right.
What's their name? What's their picture? And so we proposed, or that group proposed, and we've implemented a portion of an app that they, again, modeled after the Facebook kind of context.
Interesting.
To solve that problem.
Kathy?
I think what we learn from Facebook is that there are different ways to collaborate. And one example that we have is our clinical system vendor is Cerner Corporation, and they created a Facebook-like collaboration space called UCERN. And
For who?
for themselves initially, but then they invited their customers in. And actually, we were their first customer to take advantage of it. And we use it for collaboration around implementation projects, but we've particularly used it around the whole meaningful use regulations. They have experts who are experts in meaningful use, but are also experts in how the Cerner system works. And so there's a great bulletin board type feature with a lot of sharing. People will read something and they'll share information. So there's a lot of opportunity for collaboration that's way different than sending lots of emails.
Chuck, should doctors be using that then to share notes?
Absolutely. Well, I don't know about sharing notes from the standpoint of confidentiality, but I do believe from a communication standpoint there, and depending on what you're communicating, it might need to be in a secure email. But with Facebook, people are having a conversation about your organization, whether it's a hospital, whether it's a private practice. They're having a conversation in the community about you, and if you're not on Facebook, you don't know that's occurring. So you can't intervene when you see something that's not correct.
You as a doctor?
You as a doctor, you as an
doctor
organization. We monitor Facebook all the time, and we see where potentially a patient or a family member had a bad experience, starts talking about it, and friend after friend after friend after friend. We intervene right through Facebook, and what we hope is we get
by doing what?
We contact they friended us, so we contact them. And either sometimes it ends up being a private conversation, but what we've found is that by engaging those individuals, that what we've seen is in some cases, I did say this about the organization, but you know what? They called me, we went through the problem, and I'm very happy now. And then that goes out to the friend and the friend and the friend. So, there's ways that you can intervene with the patient. So I think, part of your patient engagement strategy, I think it really needs to be Facebook, Twitter, and things like that.
So does that seem like the big brother watching government? That would be a little scary, I think, if the hospital was able to access. Are you okay with that, Joe?
Yeah, why not? I mean, I think. Well, first of all, to answer your question about Facebook, I think not doing an IPO in May might be a good, idea. But I think there's an incredible. If you fast forward time 10 years from now, and you look at the people that are using Facebook and the people that are going to gravitate to those social networks, I think there's a tremendous amount of power around things. There's things around co-ideation that's emerging, but you start looking at having not so much a social network that's public, but private social networks where you can collaborate and exchange ideas. I think will be better for healthcare. And from a patient standpoint, a lot of times, you hear people researching and looking at, they have specific conditions, and one of the ways that they have found either some cure or something is being able to touch other people and finding the right physician or right care setting. I think having that kind of an environment and that kind of collaboration will profoundly have a positive effect for everyone. So,
Kathy, here's your wish list. If you have to complete this sentence, if I had the ideal iPhone app in the world for health, it would be blank. You can only pick one.
It would help with medication reconciliation.
Sue? The ideal iPhone app. You as a consumer of health.
I think it would be some kind of two-way communication with my my range of care providers. That where I could be doing logging of any kind of health problems or good things that I'm doing to maintain my health, that would be could be monitored and communicated with my my team of people who care about my health.
Chuck?
There was actually one I saw the other day. This is a true one that I'm actually looking at. It's called Gym Pact. And what it does is you sign up for $50 and you make a pact to go to the gym. Now you control that and how many times a week you're going to go. When you go, you get 50 cents that's put into your account. When you don't go, you get penalized $5. And the way it works is when you
What is your balance, Chuck?
I just put in another 50. And what happens is when you swipe to go in, it goes up to a website and logs you in. Now you could stand next to the treadmill and watch TV, I guess, but it does do that. And I think for me personally, I need some motivation around that because you get busy with your schedules and things like that. And I think we could all probably use a little bit more exercise. So for me, that would be something like that would be motivating.
Joe?
I just want to find out what the latest cruise is. That would be it.
No.
I really don't. I mean, I really have no magic around this. I really don't have an opinion. Sorry.
On that note,
I hate to be a downer, but I just don't have one.
so I'm going to open it up from the audience right now. Yes, sir, right here. Is there a microphone floating around somewhere? Oh, there's one right there.
So here's a question. I've seen a business model, and I'm just curious if it's viable or not. There's a company that is providing Epic as a shared service for 8 hospitals. And at a time when we see consolidation going on, standardization, all of that, we hear about the cloud. Is it feasible to have a model where you, as a provider, would turn to an outsourced service to provide EMR as a service? Is that viable pipe dream?
Who's that for?
It's for providers. It's not for.
Okay, Sue. Is that viable?
I think there's some provider organizations, hospital organizations that are doing something like that. I'm not sure if they're cloud-based for rural physicians in their region. And
These are 8 hospitals.
Okay, okay. I mean, it could be viable. If you look at, we've had Siemens on the revenue side running in a, out of their data center in Malvern, and I'm not sure how much different it is for you to look at it as a software as a service kind of arrangement.
Yeah, we actually have a regional service for some providers that are not employed at Fletcher Allen. And when we were starting to roll that out a couple of years ago, we were actually getting calls from hospitals, like in small hospitals in Colorado, because Epic doesn't sell directly to small hospitals, and they wanted Epic. They wanted Epic, and they didn't care whether the database was in Vermont or China. It didn't matter to them. So I think there is a viable one, especially for smaller hospitals. I think it's, for Epic, I think it's probably the next frontier, and I think you'll probably see them start to urge that type of entrepreneurial activity.
And how small is a small hospital? How many beds is small?
Well, critical access is 25, but I would say, well, for the Epic, anything really under, I'd say 350, depending on other types of services, they really don't market to.
I think you would need to have an organization where you bring them together to make common standards, because I think if it would not be cost effective. Part of the reason they're getting together to have this shared service would be because they probably couldn't afford it on their own. And so one of the things we've learned just by implementing the Cerner system across all of our 7 hospitals all the way, and 3 of them are critical access hospitals, is that we needed to develop standards. And so we have appropriate groups of clinicians that decide on those standards and make it so that it's more efficient. And that's why we could roll things out 1 month at a time, is because we had agreement on those standards and how the system would be used.
I was wondering if the panel could comment on some of the data privacy and security challenges that are posed by the explosion of healthcare IT.
This team seems to, they're going to put everything on Facebook. There's no privacy.
Yeah, that might.
Well, our network gets attacked 5 to 7 times every second, and we know that because we put in a SIM program that monitors, logs all the activity, whether it's spam email, viruses, that sort of thing. So we're acutely aware of that. The nefarious cave dwellers know that there is identity information in PHI. We're doing a lot with data loss prevention, encryption, just a wide variety of things. But it's expensive. It takes resources, and every time when you think you've got your hands around it, something new comes out that you've got to watch out for. So it's a very much a challenge. When I'm asked what keeps, if there's anything that keeps me up at night, it's breach notifications. That's the one thing that keeps me up at night.
Why is that any difference from, we're all very comfortable in terms of doing financial transactions online right now. So what makes healthcare, I mean, the irony here is, and privacy is really important, but if you walk into a doctor's office as a layperson and look at the stacks of paper that are sitting on the fax machine, are we really doing anything around privacy that's going to, I mean, I know we talk about the technical standards, but have we really made a lot of headway around privacy, Chuck?
No, I think we have a long way to go on the education side. I think with like a bank, you have people, who are pretty much, they're hired in the bank. They all do kind of the same thing around the banking organization. When you look at healthcare, you've got physicians, you've got CPAs, you've got nurses. They're all coming from different backgrounds and different knowledge, and you've got to get out to all of them and educate them, because they're your front line.
Right.
They're the ones who can really help you in the defense, and it's difficult to do that in a way that they understand. I'm
always amused when you walk into a CVS or a Walgreens, like, Joe Benjamin, your prescription for Lexapro is ready.
That's a breach right there.
But,
I would agree on education being key, and one of our biggest risks is just the mobility of our workers and potentially data. And yeah, that is one of the concerns that we all have, which is, you know, are we going to have to deal with a breach? We did have to deal with one last year, and it's not fun. And it was that kind of example in terms of an individual, education, mobility, et cetera.
One more follow-up. Can technology help in that area?
Absolutely. I mean, I heard a really great quote the other day, which was that the only reason fax machines exist are because of healthcare and insurance companies. You know, it's amazing to me that you know, there's a bit of paranoia, which is accurate and privacy and so forth, but yet we kind of dismiss the fact that a lot of information is still shared through paper, through faxes. And how do you possibly track that? Somebody can go in, make a copy of that, put it in their pocket or whatever, it disappears. I think the way to solve that is to have it be electronic, to be able to have secure networks that are auditable, that you know who had access to the information by whom, being able to have the right level of consent. So the other issue around privacy is making sure that there's consent by the patient. The patient is not really asked today. You know, and I think that's key.
So besides technology, it's process as well. And so he's absolutely right with the whole consent process and how do you work that. In Maine, we just got our law changed for mental health information to allow mental health information to be in our health information exchange. And that group is developing a whole separate process for actual release of that mental health information because it is seen as more sensitive.
We have a question here.
Yes, my name is Tom Smith of eFox Corporation. I'm interested, as you create patient portals, what's your approach to making the content on the web accessible for sight-impaired people and compliant with Section 508?
I'm an ophthalmologist, so that's particularly relevant to me.
I mean, we're just trying to make it work for people who can see at this point. I mean, it's really just from that standpoint, we're in the very early stages. We just went live with our patient portal probably 10 months ago. And so we're just really trying to work out the kinks of just, you know, using the English language even. I mean, we don't even have it in Spanish or any other languages. And in Burlington, there's 28 different languages in that one city. So you're right. I mean, we have a long way to go. And again, patient portals, I think, just like some of the other things we talked about, big data, very low on the maturity scale. But, you know, at some point, if we don't get there, the regulation, the government will force us. So,
yes, ma'am.
Hi, I'm Claritza from the state of Commonwealth of Massachusetts. I want to go back to a couple of your questions before. One was on the cost and pricing. There's two bills right now that the House bill that passed 2 weeks ago and the Senate bill that passed last week, merely addressing that cost issue, where providers and payers are going to have to release cost information to all consumers. The next step would be to reconcile these two bills, plus the governor had proposed last year his own bill. So reconciling the three bills and the signature of the governor will happen within the next 2 to 3 months. So we should be looking forward to have a law that will regulate that in Massachusetts pretty soon. So it's nice reading. You can go to the website and take a look at the bills there. Of course, there's a lot of pushbacks. There's going to be a lot of discussions and debates about it, but we're hoping that we get pretty soon a bill that would address cost and quality in Massachusetts. In regards to the health information exchange, that is being approached at a state level. There's not going to be a health information exchange at the national level. At this moment, or maybe not, you know, for a little while, provider networks have been doing data exchange, similar to what the panel said. But the Commonwealth is taking the leadership of creating a health information exchange platform on where Massachusetts, all the providers and payers will be able to exchange clinical data and claims data among providers. And the data analysis and statistical side of it, we already collect all payers' claims data, and the state. So we are able to analyze that data and run reports, of course, all that unidentifiable data. But yes, we are addressing those issues. So to answer your question, if we're going to have that, those two within the next 2 to 5 years, we will, because we're working on that in Massachusetts. My question is, though, what are your challenges in terms of hiring qualified staff in health information technology? It is a huge issue for us now, and I also teach at one of the local colleges, health informatics, trying to come up with the workforce to fulfill the demand. And you know, every time we post a job, we get 2 or 3 resumes that are unqualified to take those jobs. So how are you doing in terms of workforce recruitment?
Thanks for all the information. Before the question, that's a great question in terms of what we're doing about the hiring challenge, because we need many, many, many more health IT workers than we have right now. And you know the projections a couple years ago was that we would need 50,000 new health IT workers. So encouraging young people to look into that field, something I try to do whenever I'm speaking to student groups. I think that as organizations, we need to be really creative and open in terms of our hiring. Couple examples. We all want the experienced person who's worked on clinical systems to come onto our clinical systems team. Well, if we're all competing for those people, then we've got to take certain entry-level people in and grow them, right? We also have to be open to taking people, you know, at a certain point, there was a lot of people coming in from finance who were getting riffed and looking for something else. Or they were just deciding, I don't want to work in finance anymore. I feel passionate about healthcare. I've got a story about my mother and she had cancer, and, you know, since that experience, I want to work in healthcare too. And being open to the fact that people have certain core skills to transfer over and then help them learn what they need to be effective within the healthcare environment. So, you know, I encourage all of my hiring managers to be as creative as possible when we're sourcing, and being, in particular, willing to bring in young, new, in their career, people that we will then grow and hope that they stay long enough to really benefit from our investment in them.
One of the things we're doing in Maine is we're actually encouraging high school students to go into and study IT in college. And we have a program to encourage college students as well to study IT. So we just don't have enough people studying IT in Maine, and I'm sure it's that way everywhere. And so was actually a whole task force put together that was statewide to develop internships, to develop programs to actually go into the high schools and teach them about what it could be like working in IT. So there's a lot of programs encouraging that.